Welcome back, class. In this lecture, we're going to discuss heart and lung transplantation. So this is the last lecture of our course, and I think it's a nice way to kind of wrap things up because heart and lung transplantation is probably the most medically complex condition that we'll be working with as a therapist or anyone in this setting or system. So we'll go over the indication for heart and lung transplantation, like what kind of goes into the decision to get one of these organs. We'll go over the types of transplants, types of rejection, some of the other unique complications that arise after a heart and lung transplant, to give an understanding of just like the medical decisions, what the transplant team's kind of looking at, and what to be aware of if we're working with this population. And we'll go over the medications as well that are taken maybe pre and post, as well as the rehab considerations. So it's a little bit of insight. My residency training was spent at the William S. Middleton VA Medical Center in Madison, Wisconsin. Our cardiopulmonary residency there, which was also affiliated with the University of Wisconsin-Madison. Shout out to Jim Carlson and the crew out there, Tim Erickson as well, and Stacy Brixham. So a lot of my time in the first year of practice was spent working with this population specifically. So this is something that's kind of near and dear to my heart. Specialist training in this, and big shout out to the crew in Madison, Wisconsin for an excellent program. So just a little bit of insight. There are a large number of these procedures being done every year. If you look at the numbers, kidneys, we do about 21,000 of these, transplants per year. Hearts, we're doing, I think now up to 3,000. And this is just U.S. data. So we're doing a lot of these. Now, if we look, however, at the number of procedures that are done and the individuals who need a life-saving organ transplant, right? 74,000 are on the waiting list, right? And total transplantations, right? This is from last year's data, 2018 data. The number of transplants performed, right? About 9,000, right? Coming from 4,000 donors, right? And kidney donor, you can sometimes get 2. Lung, sometimes you can get 2. So this speaks to that there is an exceedingly large number of patients who need a transplant, which makes sense, and kind of like why I like to get into this lecture at the end, because organ transplant is the final solution for someone, or the ultimate solution for someone with a significant, heart failure or COPD or chronic lung disease, chronic heart disease, where the heart just, we can't support it through microcirculatory or through mechanical circulatory support like an LVAD. We need to get a new heart in there. We need to get new lungs in there. And as you know, we're seeing a large number of patients with heart failure, specifically more complex heart failure, because we can keep them alive longer. Same sort of thing with COPD and other lung diseases. So, as our population ages, as more comorbidities continue to become to pandemic levels, this is going to continue to be a big problem. There's just not enough organs to go around. We'll talk about some potential solutions to this with bioengineering, different things that we're looking on, and the evolution of LVADs has certainly helped this. But as you can see, it's a big problem. There are a lot of people who need these organs, and we just don't have enough. So we'll get into the decisions that go into giving someone an organ, because a lot of what we try to do is make sure that if we give someone an organ, that patient, right, that gift, right, that very the ultimate sacrifice a person can give to someone is given the best opportunity for success, because there's thousands of people out there that could that aren't getting it, right? So we want to make sure that when we're giving an organ to someone, that it's going to be a success, or as much a success as we possibly can make it to be. Okay, so some key transplant terms. So allograft, so you may see this referred to as a homograft, or autologous is individuals of the same species, right? So an autologous is within the same individual. So anything within the same species is an allograft. Autologous would be the same individual. So we see this often with skin transplants. So someone will take skin from if they have a burn or a significant dermal lesion. They'll take skin from an area and move it. Or we often see stem cells or PRP injections, like that's autologous. So it's taking tissue from the same individual. But an allograft is the umbrella term for anyone of the same species. Obviously, if you're taking it from yourself, you're part of the same species, right? Orthotopic is the tissue transplant is grafted into its normal anatomic position. So if a heart transplant is going to be put in the same orientation, same thing with lungs. Allogenic means it's between individuals of the same species but different genetic constitutions. So they're immunologically incompatible. So this will still be human to human, but they're not linked up. Their immune system's not exactly one and the same, or is similar, or is incompatible. And there's heterologous. So it can be heterograph or xenogeneic, so it's between individual different species, pig to human. So back in the early days, actually the first person who did I think it was a heart transplant. I think it might have been him. I think it might have been Bernard, who looked at doing, I think pig to heart transplants. No, it might have been the first guy who did the lung transplant. Either way, there were experiments looking at giving, different organs for different animals to humans. We don't do this as much anymore, but you may see this as well. Heterotropic, so transfer of an organ tissue from one party to another. We talked about skin grafts, and then homologous, corresponding to a similar structure, position, or origin. So just some key terms here. Now, in terms of complications, there are several that can occur from a transplantation. A lot of it just has to do with different stages. So rejection has 3 classifications. We'll get into that. So hyperacute, acute, and chronic rejection. They're all due to slightly different processes. So hyperacute, it's an ABO or ABO antigen mix-max. So the ABO kind of signals on your cells, right? Or the cells get recognized by your body, and they're like, wait a minute, this is foreign. We're going to attack it and destroy it. This happens within the first 48 hours after a transplantation. Then there is acute rejection, which is mediated by HLA mismatch. We'll get into that as well. And the same kind of thing, we recognize that our body recognizes, our immune system recognizes this is foreign and attacks it, right? So we see, damage to the cells of the transplanted organ. Then in chronic rejection, mediated through slightly different mechanisms. And an example we have here, looking at blood vessels, we see this kind of these changes here. So we'll get into the specifics. Infections, obviously a big concern, because these patients, once they're given an organ transplant, are going to be their immune system is going to be suppressed, so that our body takes it. Because again, we're introducing as well as we can match up people's immune systems. We can match up their different antigens, all these different things, and have a good match. It's still a foreign agent. Your body's going to recognize it as a foreign agent. It's not, your body is not attuned to knowing that this organ is here to save my life. It's recognizing, your white blood cells are recognizing, oh, this is a foreign agent. I need to destroy it, right? Because it's what we've evolved to have to keep ourselves alive. If we, had a foreign agent, like a bacteria or anything like that. So it recognizes it as foreign, so we need to suppress that response to allow these organs to eventually take, right? To get, accepted by our immune system as much as we can. Because of that, infection rate is going to be high. Kidney failure. A lot of the drugs that we give patients for managing the immune response, it can really beat up the kidney, especially calcineurin inhibitors, osteoporosis, and malignancies. The malignancies related sometimes maybe to medications, as well as just immune suppression. Like a healthy immune system is really good at recognizing these abnormal cells or abnormal proliferation of cells, and if we suppress that, can increase our risk of certain cancers. So that actually is a big concern. I've actually had a few patients, unfortunately, who we've lost to cancers after having a successful transplantation. It's one of the unfortunate things. So hyperacute rejection, again, is characterized by ischemia and necrosis of the graft that occurs at the time of transplant up to 48 hours. So this happens very, very shortly, mediated by ABO, so that, what we see, or how we pair each other up by blood type, antigens mix-max. Okay, so this happens, and why it's so problematic is that it happens before revascularization of the graft takes place. So there's no blood flow to the organ. So the manifestations, you have malaise, a very high fever, and then signs of organ failure. The problem is, like, the patient to survive will need an immediate retransplantation to survive. Because if, again, it's just not taking, and there's no blood supply. It takes a little bit of time for the blood vessels to kind of like, the fully revascularize. So they're unresponsive to treatment, and the only way to fight off the immune response is to remove the organ and find a new one. And again, like I mentioned, that's not always an option. Very rarely is an option. The other would be acute rejection. This is treatable and reversible to a degree. It occurs within the first year. So hyperacute is like the first, couple of hours, right? For first couple of days, 24 to 48 hours. Acute would be anything that happens within the first year. So it's mediated by the human leukocyte antigen. So basically, your T lymphocytes detect a foreign antigens, right? Different projections from the cellular membrane, from the graft, from the tissues in the graft, and they, the immune response is triggered. So basically, what you see, you'll see signs of organ failure, depending on the organ. So if someone's got, a heart transplant, you might see, S3 gallops, you might see jugular vein distension. These are on the right, kind of generalized signs. You might see a sudden weight gain, peripheral edema, swelling, dyspnea. They may see changes to urine output, swelling, all these different things. Again, like the body's having this kind of global immune response, and it's attacking the organ because it's recognized it as, oh man, this is a foreign thing. I gotta kill this thing and get it out of the body. So heart-related symptoms, again, you might see basically signs of heart failure, right? Because that's essentially kind of what's happening. You're having this almost myositis of the heart muscle because it's being attacked by your immune system. So you might see an S3 gallop. The patient may start developing arrhythmias. You might see some JVD, jugular vein distension. One of the hallmark signs for heart and lung is a decreased exercise tolerance. This is kind of why it can be very useful, or why, like the post-transplant, you need to be aware of this stuff because, you'll be working with these patients sometimes 3 to 5 times a week, exercising them. So if you can see, hey, like they were working out at 5 mets, yesterday, but today they can only tolerate 3 meds, and they're showing these other signs. Hey, let's get them to the transplant team. Let's get these things monitored, right? This decreased exercise tolerance is a pretty hallmark sign. That's not a good sign. Lung-related symptoms, the big one we look for is FEV1. So the FEV1s will decrease by more than 10% compared to what their baseline values are. Again, we'll start seeing decreased O2 saturation, the decreased exercise tolerance, and again, anything that looks like basically chronic lung disease, right? We've given them a healthy lung. We shouldn't be seeing those signs. And if we start seeing that, or these acute sudden changes, it could be a few things. None of them are particularly good. That calls for, hey, let's get the transplant team notified so we can manage this. Maybe it could be an infection, but it could be rejection, and it's a different scenario, and it can be potentially a big problem. All right. And then chronic rejection occurs after the first year transplantation. It's a gradual deterioration of the graft. It's progressive. You'll still see those organ-related symptoms. It might be asymptomatic in earlier stages. And again, we'll see those histological changes of tissues. So chronic rejection, again, the big timelines are that 24 to 48 hours for hyperacute. So that's like the body's just not taking it at all. And then there's acute rejection, which can occur anytime after that 48-hour window up to a year. And then there's chronic rejection, which happens after a year. That's why typically, like, the big markers for a lot of transplant success is based on the first year, right? Because that's when we know, acute rejection. That's kind of where it's going to happen. So post-transplant, again, prevalence of kidney failure, like I mentioned, a lot of the drugs that we give patients to manage the immune response can be really, really gnarly on the kidneys, and this is true for any type of transplantation, but we see this again, we're talking about heart and lungs here. And a lot of it occurs the longer you kind of get out, from transplant, the higher the risk, and it's due to just chronically being on those medications. And then post-transplant osteoporosis. A lot of this has to do, again, with some of the medications, as well as you may be on corticosteroids, like we talked about in the pulmonary unit. Steroids basically are cortisol, right? Those glucocorticoids, which can leach bone, mineral density, right, causing weakening of the bones. There also may be some issues with the other immunosuppressants patients are taking as well, but osteoporosis can be a big problem due to those steroids that patients are given. So a lot of facilities now are looking at really trying to aggressively wean people off of steroids just to prevent another complication while they're dealing with being post-organ transplant. Another complication we see are infections. So the highest risk for infections really within the first 3 months, but it can occur at any time after transplantation. It's just what I've seen. We'll show you some data from the IHLT, which talks about trends after transplantation. The general signs of infection, again, fever being a big one, temperature greater than 38 degrees Celsius, fatigue, shaking, chills, like you've all had a viral infection, maybe a bacterial infection in your day, but those kind of signs, right? Diarrhea lasting longer than 2 days, a sore throat, dyspnea, like those are all bad things. I mean, something's afoot here. And the temperature being a big one. So if we see that in a patient, we're going to make sure that we get them to the transplant team, get that managed. The other complication we may see is malignancy, right? So again, it's not too uncommon for patients with an organ transplant to develop some sort of malignancy or cancer. A healthy immune system is really important for removing those damaged, dysfunctional cells that produce these irregularities. We can recognize that and destroy it with our immune system if it's healthy. Again, these patients are chronically immunosuppressed to keep these organs from getting rejected by your body. So it sets the stage, not only for infection, but malignancies. So we typically see lymphoproliferative disorders as the most common. So various lymphomas and leukemias are kind of what we see here. So again, it's one of the unfortunate realities of transplant care, is that they may successfully get through organ transplantation and live a healthy life, but they may develop a cancer and end up dying from that. And I've known a few patients have had to succumb to that, and it's quite unfortunate. All right, so post-transplant meds. So big thing, patients are on like 30 to 40 pills a day. And it's a lot of medications. Many of them are immunosuppressants. If they have an infection, they may be given an antibiotic, and then various different minerals, and vitamins to kind of keep, again, bone health maintained and other different things, other immune functions maintained. So because of that, like patients are given like strict instructions on how to follow them, as well as their caregiver before they are discharged. This is because like if you more than anything, you need to be staying compliant with these medications. You miss one, you could be disastrous. And usually patients will go through a pre-transplant education just to make sure that they know what they need to do even before they get transplanted. Because again, if we give someone the decision to give someone an organ, you're choosing them over thousands of other people potentially, right? We need to make sure this organ's given the best opportunity to be successful in this case. So if they're demonstrating a lack of compliance or lack of just understanding, or they don't have a provider or a partner with them that can help them, it may cause them to not be listed or to receive an organ because of concerns or psychosocial concerns or these other factors. So again, don't undercount this compliance with medications. They need to know what they need to do, sometimes even before they're even listed for an organ transplantation. That's usually done in the pre-transplant workup, is all this education, seminars and stuff I go through. So some of the major ones you'll see patients are on are calcineurin inhibitors, which inhibit the action of calcineurin, which activates the T cells in your immune system. Patients will be on these typically long-term, like the entire time they're on with an organ transplant, post-organ transplant. Some facilities are looking at weaning these down. It's mainly because, again, these calcineurin inhibitors can lead to hypertension due to changes in the kidneys. They can really beat up the kidneys. So often the patient's GRF or glomerular filtration rate will be monitored. GFR, not GRF, GFR will be monitored. Glomerular filtration rate, to look at how well the kidneys are functioning. And because these two specifically, cyclosporin and tacrolimus, which are probably the two biggest ones we see, can really do some gnarly things to the kidneys, especially tacrolimus, which is probably the more common med we see now, Prograf. So calcineurin inhibitors can lead to kidney problems and hypertension related to that kidney problem. And then corticosteroids, like we mentioned, corticosteroids are anti-inflammatory, potent one. They inhibit T cell activation. They're used early on to treat rejection. Dosage is usually tempered down. Again, we talked about methylprednisone, which is that highly potent corticosteroid. Typically used more in the short term to get over that, potential risk for hyperacute rejection. And then prednisone, which is typically what patients are given long term as a pill, just to make sure that, again, like we're keeping that immune system down. The problem with that is, as we'll show here, immunosuppression, again, can lead to all kinds of issues, right? We talked about the cancers, different sarcomas, Kaposi's sarcoma, which we actually see in HIV, right? These changes there. Again, because our immune system's compromised. We can see quite often with corticosteroids, diabetes, just because of that we're spiking blood sugars because we're basically giving the body extra cortisol. We talked about the osteoporosis issues with corticosteroids, myopathies, tendon issues as well if we're giving people long-term corticosteroids. There may often be confusion or just altered mental status because, again, if you start giving people essentially cortisol, it's going to affect their mood regulation because cortisol is involved in that as well. And again, we talked about the renal failure, especially with those calcineurin inhibitors. And then you may even see certain neuropathies or paresthesias, again, due to side effects of these meds. So just because we may have had a successful organ transplantation does not mean that they're through the clear of other issues which are related to the care, post-transplant. And again, this is just some of the examples, again, of the concerns we can have with medications. So with that, we'll get into, we summarize some of the key problems or key complications related to organ transplant in general. Touched on a little bit about heart and lung. And then the next two series of units, we'll do heart transplantation, kind of what that all entails. Then we'll do one on lung transplantation, and then we'll end up wrapping up with post-transplant rehab, and then some potential, things that may arise in the future with biotechnologies. So thank you.